Yes. Hello.
Yeah, hi Debulina. Debulina.
Yeah. Hello, ma'am. Good evening.
Yeah, good evening. देबुलीना फिर मुझे इसमें तो डॉक्टर्स तो दिख ही नहीं रहे कोई भी।
मैम डॉक्टर्स इस लिंक से नहीं, आप जो लिंक से
यार
ज्वाइन किए
मैंने
थे ना।
लास्ट टाइम भी बोला था कि मुझे एक ही लिंक चाहिए होता है, फिर सेशन कैसे इंटरेक्टिव होगा।
मैम डॉक्टर लोग क्वेश्चन सेंड करेंगे तो वो क्वेश्चन मैं आपको सेंड कर
नहीं ना,
दूंगी।
मुझे चाहिए होता कौन कौन ज्वाइन हुआ, फिर आप लोग लिंक नहीं भेजते हो, बहुत दिन बाद तो लिस्ट भेजते हो, तो वही मुझे इरिटेट करता है। मैं शील्ड के साथ हर हफ्ते प्रोग्राम करती हूँ, मुझे सामने दिखता है कि कौन से डॉक्टर ज्वाइन हुए कौन से डॉक्टर नहीं ज्वाइन हुए। हाउ द
ठीक है
सेशन
मैम।
बिकम, फिर इसमें तो ऐसा खाली आई एम मोनोटोनसली स्पीकिंग और आधा सुन रहा है आधा जना नहीं सुन रहा है, वेस्टेज ऑफ माय टाइम एंड देयर टाइम आल्सो। अब मुझे कैसे पता चलेगा
ज्वाइन कर रहे, दे आर इंटरेस्टेड फॉर योर सेशन। ठीक है मैम, सो नेक्स्ट टाइम onwards we'll do it like a Zoom meeting, like all the doctors will join in the same link. ठीक है।
यस
ओके
लाइव कर रहे हो यूट्यूब पे।
हाँ मैम लाइव डन हो गया। So if you I mean if you're ready ma'am, we can start the session.
I am ready
Okay ठीक है मैम, ठीक है। So yeah, just a minute ma'am. A very good evening and a warm welcome to all the doctors present here in this CLIRnet session. Today, we are going to cover a very important topic, which is comparison efficacy of Letrozole and Clomiphene Citrate in Ovulation Induction. And to address this, we have our expert with us, none other than Dr. Ritu Santwani ma'am. Ma'am is the director at Pune Test Tube Baby Center and Shyam Women Clinic. She is also the founder and CEO of 360 Healthcare Studio, co-founder of MAAM and board member of WHCG. I would welcome ma'am to this session, and now I would like to hand over the session to you ma'am for the presentation.
Yeah, thank you Debulina, and thank you CLIRnet. So hello friends, hope all of you are doing good. Now I am today here again on the CLIRnet platform after some gap. So I know everyone is now busy in the OPD. We all are having a practice now, full-fledged practice started now. But now 2 days back, when Preeti from CLIRnet approached me, actually I've done a lot of programs along with them. So they told me, "Ki, ma'am, please do one session." So I told, yes, definitely I will do. Uh, so today I'm going to discuss with you all a very, very important topic regarding ovulation induction. Uh, I hope slides are visible.
Not yet, ma'am. You have started screen sharing. Let us.
I already started screen sharing.
Uh,
I will make it full screen. It is not full
yeah.
screen.
Now
Yeah,
now I can see the slide.
yeah. I will make it full screen. Yeah. Yeah. Visible na, Debolina?
Yes, ma'am.
Yeah,
Perfect.
yeah. Thank you. So, as always, my all the presentations will start with a small stuti to my goddess Durga Rani, as we all have gone through 3 bad phases of Corona. So my all presentation, whether the national or international, I always start with these 2 slides. I know my Mata Rani blessings are always with me. Slides are not moving, I don't. Yeah. या देवी सर्वभूतेषु चिकित्सा रूपेण संस्थिता नमस्तस्यै 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 नमो नमः. So friends, as all of you are aware of that today we are going to discuss regarding the ovulation induction. So as we all know, the 2 basic drugs what we are using, the Clomiphene Citrate and the Letrozole for the ovulation induction. So now which drug has to be used and when has to be used and what are the new protocols? So today my talk is focused on that. This you can consider as a part 1 of the ovulation induction. Here I'm mentioning about the normal ovulation induction and what we can use for the IUI patients also. And sometime again, I will take the another session in which we can discuss with the use of the gonadotropins. So friends, in this, I am going to cover what are the indications of ovulation induction, endocrine control of folliculogenesis, the agents which are used for this, what about the dose, efficacy, side effects, complications, cycle requirements in PCOS, uh, and other, and the follicular monitoring, what are the drugs to induce LH surge, role of GnRH agonist and antagonist in ovulation induction and IUI cycles, and what about the luteal phase support. So according to the definition, we all know for inducing the ovulation in the anovulated woman, according to the WHO criteria 1 and 2, either in hypogonadotropic hypoestrogenic anovulation or the normogonadotropic normoestrogenic anovulation PCOS, and for this ovulation induction, giving the ovulagens to increase the pregnancy rate in the normal ovulating woman, the superovulation, combined ovarian stimulation, and or the combined ovarian hyperstimulation for the IVF patients. Now we are coming that what are the causes of anovulation and what are the indications for this ovulation induction. Actually, this is the first question when the patients are coming to us in the OPD for the infertility treatment. Whenever we tell the patient we are going to start the drug from the 2nd day or the 5th day or the 3rd day, in between the 2nd and 5th day, the patient always asks, "Ma'am, what's the need for that? Is it not like that ki I can conceive normally without doing the ovulation induction?" So friends, now we are coming one by one the causes of anovulation. First, in the hypothalamic category, the low concentration of GnRH, weight or exercise-related amenorrhea, Kalman syndrome, stress or idiopathic. While in the pituitary, hyperprolactinemia, pituitary failure, Sheehan syndrome, cerebral radiotherapy. While in the ovarian causes, the PCOS or other endocrine, hypothyroidism and congenital adrenal hyperplasia. While the causes of infertility, so friends, as we all know, the disorders of anovulation accounts for about 20 to 30% of infertility, while 70% of the infertile patients will receive ovulation induction. So just a second. Yeah. This is a little busy slide for regarding this ovulation induction. So as we all know, the ovarian hormones which affects in the dominant follicle produces the estradiol, which inhibits the GnRH, FSH, and LH production, and which causes in turn endometrium to thicken. And I think I will take next year. Yeah. So as we all know, the follicular phase, from day 1 to 7, the primordial follicles, primary follicles, secondary follicles. As we all know, the either the atresia or the selection of the dominant follicle, single selected, constant development of the early 2 stage of the follicle, selection of one dominant secondary follicles begins with each every new menstrual cycle. So here we can see. So as we all know, in this menstrual cycle, the GnRH for the cohort selection studies have shown that GnRH pulses, the late luteal phase fall in the E2 inhibin A and progesterone levels, rise in FSH threshold, FSH plateaus and then falls, FSH window, negative feedback, E2 and inhibin B. The secondary FSH rise and pre-ovulatory progesterone rise occurs near ovulation, which in turn causes the positive feedback, initiates the LH surge, ovulation. So now, what are the key points for this regarding the role of the LH during folliculogenesis? So as we all know, friends, in the early follicular phase, the steroidogenesis, that via theca cells, the FSH receptor expresses the GCS responsiveness increases, which acts synergistically with IGF-1 growth factor increases, which increase in the preantral and antral follicles and recruitability. Then coming to the intermediate follicular phase, in which the expression of LH receptors in the granulosa cell sustain FSH-dependent granulosa activities, including the aromatase induction and growth factors release, regulation of final follicle oocyte maturation, optimization of steroidogenesis. I know all of us is having a some or the other doubt while doing the ovulation induction in our patients. So friends, if you are having any questions, please write in the chat box after the presentation. I would love to discuss with you all that. So then, as we all know, the FSH threshold initiation, the concentration of FSH required to initiate the secondary recruitment, FSH window, cohort recruitment, time for which this level of FSH needs to be maintained for follicular recruitment, growth, mono and multifollicular recruitment, LH window sealing, a substrate, the concentration of LH essential for follicular growth, and selection of dominant follicle. While with this LH surge, rise in the LH that triggers the cascade of events and ovulation happens. So here we can see the friends how it happens. So now coming to the topic which we are going to discuss today, the drugs which are used for the ovulation induction. So orally needed for the functional HPO-axis. In this, anti-estrogens, the Clomiphene Citrate or the tamoxifen, aromatase inhibitor, Letrozole, while amongst the injectable HMG, FSH recombinant or the urinary, drugs used to trigger the ovulation, HCG and GnRH agonist, drugs used to prevent the premature LH surge, the GnRH analogs, agonist and antagonist. The most common indications for ovulation induction in anovulatory patients, the PCOS, hypogonadotropic hypogonadism, while in the ovulatory patients, yes, the unexplained infertility, or the ovulation induction with IUI is the first line of the treatment. So need for the exogenous gonadotropin, FSH and LH and GnRH, define the FSH threshold, dose titration is required, or the narrow FSH window, then dose stabilization. Need to initiate the LH surge, HCG only. GnRH agonist will not work. Luteal phase support is also important. Here you can see what I have just mentioned. So which protocol has to be used and for which patient? Is it something like these in the guidelines? So no, friends, as we all know, one size doesn't fit for all. So there is nothing like there is some tailor-made protocol. So for each and every patient, the individualization, and we have to see that which protocol is going to suit for which patients. So first step, as we all know, when the tailor is making the dress, is to take the exact measurement. Similarly, whenever we are going to start the ovulation induction in the patients, we have to know that what are the all other factors. So coming one by one, firstly is in the PCOS patients. As we all know, the lot of PCOS patients in the OPD we are having with the history of either infertility or the bad obstetric history, having a first trimester abortion. So as we all know, in the PCOS, HPO axis intact, oral injectable endocrine imbalance. In these patients, the follicular arrest, sometimes recruitable pool of follicles six-fold increase, enhanced relative sensitivity to FSH in the subpopulation of follicle. Then we have to define FSH threshold, narrow FSH window, use of insulin sensitizers, AMH levels more than 7 nanogram per ml, so more than dose of ovulation induction, LH surge, agonist or HCG, luteal phase support. Usually we give luteal phase support, although it is not recommended that it is essential with the oral ovulation induction agents. So now coming to the unexplained infertility, in this the HPO axis functional ovulatory cycles. So in these patients, ovulation induction plus IUI, the first line of treatment, 20% may conceive. Ovulation induction alone is not effective. Either we can give oral and injectable drugs. And usually when we are using the gonadotropins, we are giving the luteal phase support. So now we are going to discuss one by one regarding the drugs, the CC, tamoxifen, letrozole. So friends, please do write in the chat box which protocol you are using for this clomiphene citrate and letrozole. Whether you are using the extended letrozole protocol, or if some of you have used this letrozole extended protocol, what schedule you are using and how the results you are getting. And still some of you are using the anastrozole. If yes, that how you are using, and what about the results, how you are getting the results with the anastrozole. So now in this clomiphene citrate, as we know the mode of action, the competitive binding of CC to estrogen receptors in the hypothalamus stimulates the release of GnRH, as we know. Then gonadotropin released from the anterior pituitary, leading to follicular growth, maturation, increased estradiol production, at which stimulates the ovulation. So dose, as we know, friends, the typical initial dosing regimen for CC is 50 mg once daily for 5 days starting on day 5 of the menstrual cycle. Some clinician prefers to start the therapy on day 3. Ovulation typically occurs in 5 to 12 days after the 5th dose has been taken. Maximum dose, what has been reported in the literature, 200 mg per day for 10 days. And the patients with higher BMI, we can start with 100 mg also. Some studies are for that also. So I have never used CC up to the dose of 200 mg. Actually, I always use in combination with gonadotropins, the maximum permissible dose What I have used is 100 mg. So friends, as any one of you have used the dose up to 200 mg, so please share your experience. Do comment in the chat box. Debolina, please keep an eye on the chat box. If some doctor is replying, let me know in between.
Sure, ma'am, sure.
Yeah. So friends, as we all know, the success rate for this, the efficacy is ovulation rate 70%, pregnancy rate 40%, and in the multiple pregnancy rate 8 to 10%, while the CC resistance, when the failure to achieve ovulation, has been reported in 20-25% of the patients, 150 to 200 mg for 3 cycles, while the CC failure 60%, in which the failure to achieve pregnancy despite ovulation in 6 cycles, or the persistent thin endometrium, which is very commonly seen once we are using the CC. So longer half-life and receptor depletion, prolonged peripheral anti-estrogenic effects, cervical mucus, dryness of vagina, itching, discharge, endometrium thinning in 15 to 50%, higher incidences of miscarriage, decreases the blood flow during the early luteal phase. So the disadvantages of this is ovarian cyst formation, abdominal discomfort, abnormal uterine bleeding, breast tenderness, and blurring of vision. So now coming to the next drug is the tamoxifen. These days, tamoxifen we are using in the patients we are having thin endometrium, or in the patients with a family history of breast cancer. The dose has been recommended is 20 mg per day for 5 days starting on day 3, or the 40 mg per day if no response. The advantage of this drug that no anti-estrogenic effect on endometrium and cervical mucus. So coming to the now the drug which we all are using these days, right and left, regarding the letrozole. So aromatase inhibitors, the dose administration schedule is similar to CC, one daily for 5 days, beginning on the cycle days 3 to 5. The letrozole 2.5 to 5 mg, anastrozole 1 mg. But I don't find any results with this anastrozole. So though I have tried in the higher doses up to 2 mg also. So the advantage of this letrozole, the studies all have shown the reduced incidence of multiple gestation pregnancy compared with CC because of the development of fewer follicles. Pregnancy rates with letrozole appear to be similar as those of the CC. So yeah. So friends, as we all know, these are the aromatase inhibitor. Aromatase is an enzyme which catalyzes the rate-limiting step in the production of estrogens. It is a good target for selective inhibition because estrogen production is a terminal step in the biosynthetic sequence. Here we can see. So now regarding coming to the mechanism of action, how this drug acts. So friends, as we all are aware, administration of letrozole from day 3 to 7 results in the suppression of ovarian E2 secretion, reduction in estrogen negative feedback at the pituitary and hypothalamus, increased FSH secretion from the anterior pituitary results in the stimulation of multiple ovarian growth. While later in the follicular phase, the effect of letrozole is reduced and E2 levels increase as a result of the follicular growth. Because the letrozole does not affect the ER centrally, but the increased E2 levels result in the normal negative feedback on FSH secretion, follicles are Follicles less than dominant follicles undergo atresia with the resultant monofollicular ovulation in most of the cases. Because these days, whenever we starting the ovulation induction to the patients, the first query in the patient's mind, ma'am, kahin mujhko twin to nahi ho jayenge? How can I handle with the twin pregnancy or the triplet pregnancy? So, just a second, need about. So, with this letrozole, the dose recommended, as we know, the 2.5 mg per day, cycle days 3 to 7 following a spontaneous menses or progesterone-induced bleed. If the cycle is ovulatory but the pregnancy has not occurred, the same dose should be used in the next cycle. But if the ovulation is not occurring, then the dose should be increased to 5 mg per day for cycle days 3 to 7 and the maximum dose of 7.5 mg. And here we know the sequential dose escalation of 2.55 and 7.5 mg if the ovulation does not occur and occurs on the lower doses is widely used for the reproductive endocrinologist. So the either letrozole sequential escalation protocol or the step-up protocol, which is considered a successful super ovulation protocol. So, as we have just discussed, in this, the sequential dose escalation of 2.5 to 5 and 7.5 mg if the ovulation does not occur at lower doses and is widely used by the reproductive endocrinologist. Means in one cycle you're trying with 2.5 and another with 5 and third cycle we can try with 7.5 mg. Of course, after seeing the all other parameters regarding the BMI, body weight, all the other things also we have to have a look. So the studies have shown from the ASRM guidelines the effectiveness of letrozole escalation protocol in achieving the ovulation in patients with PCOS. The study has been presented by T.L. Jones and C. Coddington. So conclusion by this, the escalation protocol increases the ovulation rates in patients with PCOS by effectively identifying the letrozole dose necessarily to achieve the follicular recruitment during the initial phase of the ovulation induction cycle. Immediately increasing the dose of the letrozole in a single cycle does not exhibit the detrimental effects on the number of the follicles recruited, endometrial development or pregnancy rates. So friends, here you can see for this the letrozole extended protocol. As we know, we start with 2.5. This in extended protocol day 3 you can give 2.5, then in day 4 5, and in day 5 7.5, and day 6 10 mg. So the studies have shown that with this step-up protocol, it is associated with multifollicular ovarian development and a tendency for a higher clinical pregnancy rate treatment cycle compared with CC was also observed with the letrozole step-up treatment. So the conclusion by this study is that contrary to the monofollicular development associated with single and multiple fixed dose letrozole regimens, the step-up protocol was associated with multifollicular development. The step-up letrozole protocol thus increases the duration of elevated FSH, resulting in multifollicular development. The new protocol could prove useful for ovarian hyperstimulation and for assisted reproduction. So, So these are the different studies which have shown that how with the use of the different drugs, what about the ovulation induction rates. So friends, here also you can see among this is the study has been presented in the long back 2011, where they have shown the pregnancy rates are higher in the letrozole plus FSH. So here we can see, friends, that overall pregnancy rates are associated with the use of an aromatase inhibitor for ovarian stimulation. So the studies have shown the comparison of letrozole with and CC in the woman with PCOS undergoing the ovarian stimulation. So studies have shown the letrozole was compared with CC as a first line of treatment for ovulation induction in females with PCOS. So friends, the studies have shown, the study has been supported by the Journal of Internal Medicine. The studies have shown the number of the mature follicles was significantly lower, but endometrial thickness and ovulation and pregnancy rates were significantly higher in the letrozole group compared than the CC group. While the studies have shown that in conclusion, letrozole is associated with higher pregnancy rates than CC in the PCO patients and may have a role as a first-line treatment for the anovulatory patients with PCOS. So, friends, we know there are a lot of literature and studies for the use of the letrozole for the ovulation induction for the PCOS, IUI, IVF, ICSI patients. So studies have shown that letrozole versus CC, the studies have shown the letrozole was better than CC for ovulation rate per patient. Just a second, friends. Yeah. So the advantage with this letrozole that it has been used for the IUI also. The main advantage with this drug is reduced requirement of gonadotropins and reduced chance of multiple pregnancies. So the study have shown in the PCOS patients too. So now for the comparison of the efficacy of letrozole and CC in ovulation induction in Indian women with PCOS, the study has been presented. And the studies have shown that letrozole has a beneficial effect on the endometrium. So a lot of studies by the different journals has been reported. Yeah. So studies have come regarding the fetal safety of the letrozole and CC for ovulation induction. Some studies have shown that studies have shown clearly the letrozole is not a teratogen. Some studies have shown that with the CC, the result in the small for gestational infant. The use of letrozole for ovulation induction does not appear to increase the risk of congenital malformations and does not affect the birth weight. So studies have come regarding from this mother is update. The study has been presented by the Myla Moretti and Gideon Korean. They have shown we can see in the abstract, the use of letrozole to induce ovulation has not been associated with an increased risk of a child being born with a birth defect. In contrast, the CC in pregnancy associated with IUGR. So the friends, there are a lot of studies that as a topic is very vast. I tried to summarize. So letrozole to induce ovulation does not appear to be associated with an apparent increased risk of major congenital malformations in the human. So the study have also shown the use of the letrozole to induce ovulation should be considered for the women who are wishing to conceive, especially if the CC is failed or the CC resistant. So friends, these are some studies which are showing that congenital malformation among the 911 newborns conceived after infertility treatment with letrozole or CC. So friends, here we have seen it is 4.8% in CC group, while in the letrozole group it is 2.4%. So friends, here again a beautiful chart by comparing the both the letrozole and CC. So here we can see it is not like that these are in the major. So the studies have shown for the following congenital anomalies, the malformation rate, ventricular septal defect, congenital cardiac anomalies, or the minor congenital anomalies. So the main suggested approach based on the half-life of each drug administration in the early follicular phase should result in the clearance of letrozole before the implantation takes place. So yes. I hope last two lines are clear to you. So now, what are the ovulations we are using? The letrozole as a drug of first choice, then CC as second, and tamoxifen we are using in the patients where the ovulatory response is good, but the peripheral anti-estrogenic effects are more, like thin endometrium. While the next step for this is the gonadotropins. So, as it has mentioned, if the oral ovulations are not successful, but what I prefer, I usually given the combination for the good results, because standard protocol involves some daily injections of FSH and combination of FSH and LH to stimulate the follicular development. So friends, this we have just discussed earlier, so I'm skipping this slide. So for the gonadotropins, the two other protocols for step up and step down has been mentioned. So I think I have focused my talk today on CC and letrozole. So this I will cover in the next lecture. Here the diagram for the PCOS ovaries. So gonadotropin, I think I will take the next session for the gonadotropin only. Today we will focus on this CC and letrozole only. So as we all know, the follicular monitoring is must while we are giving this ovulation induction medicines. So serial monitoring is also very, very important. So while in some patients there will be no response with this, so now what are the predictors for the poor ovarian response? The ovarian volume less than 3 cc, less than 3 antral follicles, ovarian resistance index is more than 0.6, PSP is less than 5 centimeter per second, and stromal flow less than air. So with this slide, I will wind up the CC. As we know, friends, the larger follicle early in the cycle, cystic follicles, the poor blood flow to the follicles, thin endometrium, poor blood, and flow to endometrium and utilize unruptured follicle incidences. While with the letrozole, the larger follicle size early in cycle, and we do not have to give the trigger unless the follicle is reaching more than 20 mm to improve the oocyte quality. Perifollicular blood flow is good. Endometrial thickness and vascularity. um, so induction of LH surge, the ovulation trigger, the HCG, SG and RH agonist. So the HCG, what we are using is 5K or 10K, the lowest effective ovulatory dose, 3000 international units, longer half-life, maintenance, corpus luteal, increases the progesterone support and luteal support. Uh, Now for this, what to give the trigger? So as we know, usually we are giving the HCG 5000 to 10,000. But what about the GnRH agonist trigger? Studies have shown the shorter half-life than HCG. Either the decapeptyl or leuprolide we are using. Doses I have already mentioned. So equally, so friends, here we have seen it is equally effective in inducing the LH surge. OHS was significantly lower. So luteal phase support, again a very vast topic. So yes, it is very important in the cycles where the gonadotropins has been used. So for this luteal phase support, what we are using is a either the micronized progesterone for this vaginal gel or capsule, or the dydrogesterone 10 mg BD or DDS. So thank you, friends. I tried to summarize, as today's our topic of the interest was this CC and letrozole. Next time I will share with the along with the use of the gonadotropins too. So thank you for your interest and time, and once again thanks CLIRnet for inviting me.
Thank you, ma'am. Thank you so much for the wonderful presentation. And we have some already received some queries that I would like to share with you, ma'am. First
Okay.
one is from Dr. Rashmi Solanki. What are the FDA warnings for the use of statins?
What are the
FDA warnings for use of statins.
use of
Statins.
statins?
Yes, ma'am. I'm also sharing the question in the chat box.
Okay. See, statins you are using for what, Dr. Rashmi? Statins are you using for the treatment of the PCOS? Yes, some guidelines have, but still there are a lot of papers are there, but still from the FDA there are no clear-cut guidelines for the use of that. So if you are using in the PCOS patients along with the ovulation induction, so I must say, no, don't prescribe in that prescription. See, lot of company persons are coming and meeting us for the use of this statins for the treatment of the PCOS hyperinsulinemia. But till now, as per my knowledge, we are not having this is approved for this PCOS ovulation induction.
Thank you, ma'am. Yeah. Next question is from Dr. Rimjim Jain. What are the pharmacologic treatments for polycystic ovarian syndrome?
So hi Rimjim, how are you? Rimjim, I think you have missed the earlier session. Please go through from the session from the earlier. I've already discussed this. The session has gone live on my YouTube. You can go through that.
Okay, ma'am. Thank you. Next question is from Dr. Chetan Charva. Dr. Chetan wants to know how effective are lifestyle changes in the treatment.
Very nice question, Dr. Chetan, na? Chetan, na? You told.
Dr. Chetan, yes.
Yeah. Chetan, of course, whenever we are using this, starting the ovulation induction, of course, the lifestyle plays a very, very important role. Especially if I'm talking about the Pune, where I practice in Koregaon Park. Yes, see, mere यहाँ पर weight is not a problem because all the patients what I am getting are very super fit, and they are very conscious about their diet also. Here, the main problem is the smoking and alcohol. So yes, lifestyle matters for all, for this smoking, alcohol, obesity. So if the patient is the overweight, so we always suggest the patient to at least minimum for the 10% of the weight reduction. Of course, also brings the spontaneous ovulation. and cutting down of the smoking and alcohol is also very, very important. So this all depends upon the area, which area you are practicing, because in my area, obesity is not a problem. My area, the smoking and alcohol is the major problem.
Thank you so much, ma'am. I hope Dr. Chetan, you have got your answer. So next question is from Dr. Sumita Vargava. What do elevated mean platelet volume levels suggest in women with PCOS?
I also don't know why you have done this elevated platelet volume in women with PCOS. For which purpose? For which purpose? Sorry, I am not aware about this. Elevated platelet volume for why you are doing that test in the PCOS patients? For what indication? If you can clarify, doctor's name is what?
Dr. Sumita Vargava.
Yeah. So, doctor, please, if you clarify, that will be great. That for what, which indication you are doing this, the platelet counts in the patients of the PCOS.
Sure. I would request Dr. Sumitra, ma'am, if you are on the session, please clarify your question so that we can proceed with the answer.
So we all will get some knowledge for that.
Right, ma'am. So moving on to the next question, which is from Dr. Richa Sharma, role of leuprolide acetate.
Yes, leuprolide acetate for what? Please clarify your full question. For what leuprolide acetate you are asking, Dr. Richa? For what you are asking? See, today I am not covering. Today I am covering only this Clomiphene Citrate and Letrozole for the basic ovulation induction. Now, for what you are writing for the leuprolide acetate, you want to know from me for the
sorry for the interruption. Dr. Richa is writing for PCOS.
About PCOS, for why you want to give the leuprolide acetate? Let me, Dr. Richa, please clarify why you want to give the leuprolide acetate.
Sure, I would request Dr. Richa, so please explain your whole query so that we can get the answer. Next question is from Dr. Poonam. If a patient gets regular periods and maintain WT reduced, how long to wait before induction?
Wow, this is a very nice question. If patient get and maintain weight. Again, please show me.
It's in the chat box, ma'am.
In the chat box, huh? Yeah, if patient gets regular period and maintain weight reduced. I'm not getting maintain weight reduced. How long to wait before induction? Why we have to wait? See, in fertility treatment, please don't wait. Otherwise, the patient will run to other doctor. As soon as the patient will come, please do the test, all the test in the first cycle only, and please start the ovulation induction. See, because in my patients, I always start the ovulation induction directly from the 100 mg with the CC. I never start with the 50. So actually, this is offline what I'm here sharing with you all. A patient को अगर एक cycle में 50 से करेंगे, फिर response नहीं आएगा, then other cycle you are going with 100. So if you are doing sonography by yourself, of course we can monitor easily कि patient को कैसा result आ रहा है. No, why we have to wait? No, please, as soon as you are seeing that patient is getting the good result, so you can start the ovulation induction. Why to wait? No need for the wait.
Okay, ma'am. Thank you so much. I cannot see any more question. I hope, ma'am, you have already covered the things so beautifully. So this is the last announcement to all the doctors. Any other question, any feedback, if you would like to share with us, please prefer the chat box on the live session page. There is option, write your comment here. You can use that option to share any views from your end, or else we are going to close the session here for today.
So I think we will close. I am also actually very tired from the whole day.
I got from your voice, ma'am. Understand. So I think, ma'am, with this we can conclude the session here.
Yeah.
And thank you so much, ma'am, for your precious time that you have spent on this platform to share knowledge. Thank you.
Most welcome. Okay, friends. Bye. Connect with you all soon again. Bye.
Sure, ma'am. And thanks to all the doctors for taking part in this session. Please stay tuned with CLIRnet for such more amazing session by Dr. Ritu Santwani, ma'am. Thank you so much.
Bye, dear all. Bye.